Hi, everybody. I think it seems like most people trickled in already. We might have a few people join, but I'm Dr. Kimberley Thornton. I am one of the reproductive endocrinology and infertility physicians here at RMA of New York. And tonight I was going to talk about egg freezing. Kind of start out talking a little bit about what happens to female fertility with age and time, why we worry about fertility as we get older, what is egg freezing, what's the process like, what testing that we recommend doing for somebody who's interested in the process, so I can get you all the medical information. I can see who's logged in, but I can't physically see you. So if you have any questions along the way, please don't hesitate to enter or type into the chat at the bottom of the screen. And at the end, I can answer any questions that come in. So to start out, why do we worry about fertility with age and time? So most women know that we worry as we get older and especially after age 35. But this is mostly because all women are born at birth with every single egg that they're ever going to have. And so as women, we don't have the ability to generate or make new eggs. Most women start out with a couple million eggs. So it's this really big surplus. Nobody's having a million babies. The problem is we lose those eggs very quickly and very rapidly. And at some point, we all hit menopause, which is when there are so few eggs remaining in the ovary that they essentially fail. We don't get our periods anymore. And for most women, that happens in their late 40s or early 50s, although everybody is an individual on that process. Some people inevitably lose eggs a little bit faster, some people a little bit slower. There is likely big genetic components involved in this. And so a certain degree of this, unfortunately, is completely out of our control. We often see very similar patterns amongst siblings, how quickly eggs are lost. But certain environmental factors can also impact things. So, for example, like heavy tobacco use and smoking, we see those individuals go through menopause a couple years earlier than non smokers. In certain medical disorders, one of them being endometriosis, does have an association with egg loss at a younger time point. At the end of the day, the main reason we worry about fertility well before those menopausal years, those late 40s, early 50s, is the second big age related factor that really kicks in much sooner is the quality of those eggs starts to go down with age and time as well. Those eggs have been there since we were born. And so the older we get, they are essentially sitting around longer. And some of the proteins holding our genetic information together can start to break down to the point that when those eggs fertilize to become embryos, those embryos become much more prone to making spontaneous genetic abnormalities, things that are not inherited, that are not passed down into families. So, for example, a healthy individual typically has 2 copies of all their 23 chromosomes. So, if you think all the way back to high school biology, we get 23 chromosomes from the egg and 23 from the sperm, and they come together in pairs. That's what we want to see in a healthy embryo. But embryos sometimes make mistakes. Sometimes they accidentally leave out chromosomes or take on extra ones during all that rapid growth and division that happens early on. There are thousands of genes on our chromosomes. So if thousands of genes are missing or thousands of genes are triplicated, it is drastically abnormal to the point that 98% of the time, those embryos are not going to be live births. Most of the time, our bodies do a great job. We often filter these abnormal embryos out. And a good portion of the time, we don't even get a positive pregnancy test. If we do get pregnant with an abnormal embryo with missing extra copies of chromosomes, this is the number one cause of a miscarriage in the first trimester of pregnancy. And then Down syndrome, which is 3 copies of chromosome number 21, is one of the very few that's potentially compatible with life. It's in that 2% that can be a live birth. So most individuals are a little bit more familiar with that disorder. So at the end of the day, when we start saying the quality of our eggs declines with age and time, what we actually mean is the percentage of embryos that make spontaneous genetic abnormalities, most of which are not viable, starts to go up. And the really, really tricky part about this is there is no test for egg quality. It does not exist. There is no way to test someone's blood and say, okay, their eggs are better or worse than the average person in their age group. It is really strongly linked with age. So, unlike quantity, where we see a lot more variation based on age, lifestyle factors, medical disorders, it's pretty unusual for people to fall outside their age categories. So, I can give you percentages based on that. Most women under age 35 are what we consider like the best quality eggs, lowest risk of abnormal embryos. And it is still 25 to 30% of all embryos have an error or mistake, even in that age category. So that's truly about as low as we see in life. And then at 35, it starts to creep up to closer to 40% of our embryos have a spontaneous abnormality. And then it just keeps going up after 35. Most women in their early 40s, 80 to 90% of their embryos are abnormal and non viable. And this truly becomes the number one reason it is so much harder to get pregnant, especially in our late 30s and 40s as we age, is because, yes, like the quantity or the number of eggs starts getting lower and lower, but it's really more that the quality of what's there becomes so much poorer that it makes it more challenging for things to line up. And once we get to those points, it's hard because there's not much we can do. There is no medications or supplements that to any significant degree have been shown to significantly improve egg quantity or quality. Even IVF success rates on national averages at above age 43 in the United States can be closer to a 5% chance of live birth per cycle because so many individuals have so many abnormal embryos at that point in time. And so this is truly why some people start thinking about options like freezing eggs. The main benefit of when we freeze eggs is the quality of those eggs stay the age we freeze them at. So that if somebody ends up struggling to get pregnant later on in life and that they have eggs frozen from a younger time frame, their chance of pregnancy would be of that younger time frame self, not of that later, not of the current times, meaning like if someone froze their eggs at 33 and then they were struggling to get pregnant at 43, their chance of pregnancy would be more of their like 33-year-old self versus their real life time frame self when we freeze. And so that is why some people, depending on how many children you want to have, how you plan to space your pregnancies, like how many years apart between them, and or some people truly, if they have no sense of when that timeline is going to be and they're not sure if there is any realistic probability that majority of those pregnancies or any of those pregnancies may be in the years that are our late 30s or 40s, it's sometimes a good option to think about freezing. How egg freezing works, I always kind of tell everybody egg freezing or embryo freezing or IVF, they are all the same process in the sense that the medications, the growing and extracting of the eggs is identical for all three procedures. It is sort of like being on a train, and egg freezing ends up being the first stop off the train. So after we grow and extract the eggs, we freeze and stop there. Some people prefer to freeze embryos, meaning we can fertilize those eggs to create an embryo and freeze and stop there. And there are some medical advantages to freezing embryos over eggs, which we can talk through. And IVF is you've done all that process and we transfer the embryo back into the uterus. And so different people, depending on where they're at in life, may be pursuing this for different reasons and stop at different time points. If someone is ever thinking about freezing their eggs, usually you sort of pick a month that you plan to do this, and we typically start you on medications when your period begins. So the first day of your period is day one of your menstrual cycle, and we typically start the second or third day after that. Now, there can be some variations. Some people have IUDs where they don't get their periods. Some people are on birth control pills. So, these are definitely things to talk through with your physician in consultation. It's not really the period or the bleeding that's important. That is when most people's estrogen and progesterone hormone levels are low. So, sometimes with IUDs in place, we just have to track the hormone levels to see when the right timing is to start. For things like birth control pills, we usually take you off of the pills for a couple of days before starting. But the main reason or the main science or what we're doing is at that time frame each month, it's when your body is not pregnant and your brain is starting to signal to your ovary, I'm not pregnant, like I need to grow an egg. And so even though we are born with all of our eggs and we have thousands of them, they're sort of like locked away in a vault deep inside our ovary is a way to think about it. And they're stored there what we call immature, meaning they can't fertilize or become a baby yet. So for all women, each month our bodies release a whole group of eggs to the surface of both ovaries from that total vault of eggs. Naturally, our bodies panic. We are not puppies, we are not kittens, we are not supposed to have seven babies at the same time. So, our pituitary in our brain normally releases only enough hormones to allow one of those eggs to ovulate and release. And all the rest from the group that started to grow with that one, we just discard and get rid of. So, we lose this whole group of eggs every month, even though we only ovulate one. So, what we are doing with egg freezing is it's unfortunately pretty much all injection medicine. So, they're like little tiny injections or shots that go on our belly that are we typically are on twice a day, morning and evening, for about 1 to 2 weeks. And these are the hormones our pituitary and our brain normally produces to grow that one egg, but at higher doses to try to get the whole group of eggs to grow. So we essentially are trying to rescue those extra eggs that your body naturally would have discarded if we hadn't grown and extracted them that month. This is truly the benefit and the limitation of the technology all wrapped together in one. The benefit is if somebody freezes their eggs or if somebody is doing something like IVF, they are never going to have less eggs than if they had never done this process. It is not going to accelerate your total pool because those eggs were going to be lost if we hadn't extracted them. Why I say it's the limitation is at the same time, our medications only have the ability to grow the group of eggs that your body naturally released to the surface of the ovary that particular month. This is why we never get thousands of eggs per retrieval cycle. It is physically impossible. It is truly why some people are like, well, my one friend got 5 eggs and my other friend got 19 eggs, and why there's a lot of variability on the number of eggs that can be extracted per retrieval cycle. And this is truly what most of our testing is really looking at for egg freezing is to get a sense of how somebody may respond to medications. And this is really strongly linked to egg quantity. So, quality we can't measure, but quality tends to be very strongly linked to age groups. But egg quantity can actually be measured. There is a blood test. It is called an AMH level, and it tells us where somebody is at on losing eggs. Like, is somebody average, above average, below average? You somewhat need to take it with a grain of salt. It does not tell us anything about someone's ability to get pregnant naturally. People mistakenly panic when it's low and think it means they can't get pregnant. People tend to feel overly reassured when it's elevated and that they don't have anything to worry about fertility wise. If somebody was 35 and they had a million eggs left in their ovary, and let's say someone else is 35 and they have 1,000 eggs left in their ovary, well, back to the we are not puppies or kittens, both people would still only naturally ovulate one egg per month, which is why we don't see any differences. It's not a prediction of natural conception. The only reason I care about it, the only thing it actually is a predictor of, is how many eggs we can likely extract in a single cycle for egg freezing, embryo freezing, and IVF. Individuals who tend to have more eggs left or higher AMH levels, their bodies naturally have more eggs they can afford to lose. So they tend to naturally release higher number of eggs to the surface of both ovaries every single month. So they often are a little bit more sensitive to medications in the sense that they can get away with lower doses of medications, and they're more likely to get higher numbers of eggs. Like usually we consider somewhere between 10 and 15 eggs to be a really high solid number. But sometimes if someone's really above average, they might even be able to get a little bit above that. But women who start to have lower egg counts or less eggs total in their ovary, our bodies really start to conserve and hold on to the eggs we have left. And we start to release smaller numbers each month to sort of slow down how quickly we lose our eggs. One of the really interesting things is a lower AMH level or egg count at a younger age is not a strong predictor of early menopause. And that is because we conserve, we hold on to our eggs, and we release smaller numbers each month to slow down how quickly we lose what we have left. But it can make egg freezing a little bit more challenging because those individuals tend to be more resistant and need high doses of medications. And sometimes truly 4 or 5 eggs is the best we're going to be able to get from a single extraction cycle. So, egg quantity helps your fertility doctor know what medicines and protocols would be best for your body. It helps us give you expectations on a range of eggs that you could likely extract in a single retrieval cycle. But that's truly the limitation. That's all it tells us. It doesn't tell us anything about the quality of someone's eggs, if they will get pregnant now, if they'll get pregnant in 5 years from now. There is truly no test that will definitively tell us if somebody will be able to get pregnant naturally or not. We don't ever know for certain until they actually try. The one disadvantage of if a count is lower is sometimes realistically, depending on what someone's goals are, depending on their age and how many children they want to have when they're freezing, is you may want to strongly consider doing more than one retrieval cycle if it looks like you won't be able to meet those goals in a single extraction cycle. The blood test usually comes back very quickly, most of the time within about 24 hours. And we often pair that when you come in for a consultation with a baseline pelvic ultrasound to count what we call follicles. They look like little black circles on your ovary. They're fluid pockets, and one egg is floating in each one of them. The eggs themselves are just microscopic. We can't see them on ultrasound. So, by counting those follicles, we can get a sense of how many eggs your body started to grow that month. It tends to be very similar in short time frames. And so, we use that in addition to the blood work to kind of give you a sense of how you would probably respond to medications or where you're at egg quantity wise. When you're on these medications for egg freezing, these injections, everybody typically is on them for at least a week. I really never see anybody ready faster than that. Most of the time, you shouldn't be on them longer than 2 weeks. But it's a little tricky because when you start, we never know the exact day your eggs will be ready. And so most individuals have to come for an ultrasound and blood work almost every other morning when they're on the medications to see when their eggs are ready to be extracted. And here at RMA, we typically do those check ins between somewhere between 7 and 9 a.m. in the morning to try to not interfere too much with the rest of your day because we know it's a lot of appointments. What we're looking at on ultrasound is those follicles I was talking about, those little black circles. They truly expand, they become big black circles as the egg inside is having the ability to fertilize or what we call mature. So the size of what we're seeing on ultrasound is a huge determinant on when the egg should be extracted. And eggs make hormones. So I'm always checking the levels in your blood to see how to titrate up and down the medications along the way. Once your eggs are ready, we plan for what's called an egg retrieval. So, usually, the day you're ready, we're like, okay, tonight you're going to take your last medication, what we call your trigger medicine, and we schedule you for an egg retrieval, which is always done not the next day, but the day after. Meaning, if somebody is ready to take their last medicine on a Monday, the egg retrieval would be a Wednesday morning. Or if you're ready on a Tuesday, it would be a Thursday morning so that you always get a little bit of definitive notice and planning. But it is tricky because you often don't know too much further out than that. And an egg retrieval is a day that you don't want to go to work if it's a work day and you don't want to have any big plans going on that day. It's a very quick procedure. It is a minor procedure. It's about 20 minutes start to finish, but we put you under a little bit of twilight anesthesia so you take a nap. And while you're asleep, we place a needle through the wall of the vagina and take the eggs directly out of the ovary. And so you never know how you're going to feel after anesthesia. Most people can go home about an hour later. Most women are fine with just Motrin and Tylenol for pain control by the time they go home and can return to work the next day if you do not have a very physically active job. But we don't recommend having any, big event or anything that you have to go to in case you feel groggy or in case you feel tired after that egg retrieval. When you have the egg retrieval, we know how many eggs are extracted before you go home. So we drain those little fluid pockets that we've been measuring. And under the microscope in the laboratory, the embryologist will count out the eggs. That is sort of where we stop with egg freezing. The embryologist will spend the afternoon cleaning them off. They will check to make sure that they've matured or have the ability to fertilize. Unfortunately, some eggs often don't respond to the medication. So there are usually going to be a few that might not be able to be frozen. And we get the final report the next morning to update you. And then you're done. No more medications. You don't have to come for those every other day check ins anymore. Most individuals get their period about 10 to 14 days after the egg retrieval, and then your cycle sort of resets back to your normal natural cycle from that point on. And then if somebody was on birth control pills, that period is when you could restart them. Or if someone wants to do another cycle, that's the fastest you could do another retrieval cycle, though they don't have to be done back to back in that regard if someone wants to do more than one cycle. The big side effects from egg freezing is the medications cause a lot of abdominal bloating and swelling. Your ovaries are normally the size of two small lemons, and from all those fluid pockets growing, they truly swell and become like two big oranges. So, individuals really feel that. All of a sudden, you have two things taking up more space in your abdomen or belly. Most people feel puffy and full. It is water weight, it is swelling, it will go away, but it kicks in about 4 or 5 days in on the medication. And I would say it's a good week after the retrieval before it goes away completely. It is not recommended to do any strenuous exercise or physical activity when you are feeling that abdominal bloating and swelling. So you shouldn't be doing a lot of running, jumping, or abdominal work, things that are going to put pressure on your abdomen and belly. It is okay to walk. It's okay to ride a bike, like sitting and pedaling, not jumping up and dancing all around like Soul Cycle. You have to take it easier, but you don't need to be bedridden, but you need to be mindful of your activity during the time frame. How many eggs to have frozen really depends on age and goals of how many children to have. So the older somebody freezes their eggs, that number is always going to be higher as the quality of what we expect to be not as good or maybe potentially more abnormal embryos, while at younger ages we often can get away with less eggs. So those are definitely very tailored conversations to have with your fertility specialist if you're thinking of freezing eggs, is to kind of review your goals. Not everybody necessarily needs enough eggs frozen for every single child they may want to have, depending on when you think you'll start your family. Sometimes people may not be starting their first child too far off, but are freezing more for second, third children down the road. Other individuals is, they're not starting their family anytime soon. They want a large family and they do want to freeze for everything. So those are definitely very tailored and individuals conversations, but you always want more eggs frozen than children you want to have because there is always a drop off. One of the huge limitations of freezing eggs is we only can see that they could fertilize and how many you have. There is no test when we freeze eggs to say this is a good egg, a bad egg, this one will fertilize, this one won't. And so most individuals, there can be about a 60 to 70% drop off from eggs to what makes it to an embryo stage, meaning like 10 eggs for very average couple could be about 3 to 4 embryos. And then depending on someone's individual age within those embryos, we will still see a certain percentage of those spontaneous abnormalities. Most healthy, genetically normal embryos are somewhere between a 50 and 70% chance of live birth per embryo. So we don't need 10 healthy embryos to have a baby. But I would say goal wise is usually to have at least 2 healthy embryos per live birth that we're trying to achieve. So there is very much safety in numbers when it comes to egg freezing. So we do always like to try to have that large group to account down for the fact that there will be some funnel down if somebody wants, ever needs to use those eggs in the future. These are reasons why some individuals do think of freezing embryos rather than eggs, is because the process, the extracting of the eggs is identical. It's just rather than freezing, we take a sperm, we put one directly into each egg, and the next day we can see how many fertilized normally. And a week later, we can see how many made it to what's called the blastocyst stage, which is the stage of an embryo when it could be transferred back, and embryos can be tested. We can test for those spontaneous abnormalities before freezing them. So we can gather a lot more concrete data from embryos than we can from eggs. But embryos can socially be much stickier. Eggs are somebody's, you know, personal property. It leaves you open to whatever sperm source you want to use down the road and future. And of course, some people freeze embryos using donor sperm and don't have to worry about that second half. But if it's with a partner and there was ever some sort of disagreement, people can fight over embryos. There's been court cases about it. So it socially can be a lot stickier and than freezing eggs. And so it's something some people consider, but it's something that you would have to make sure both parties felt very comfortable with if it was outside of a scenario besides something like donor sperm, where the person who eggs has sole custody and property of them. So that's sort of a brief overview. I see that we got a lot of questions here. So I'm going to kind of go through and answer some of these questions so that way, and then you guys can continue to put any further questions in the chat. So I think the first question I got was if we said at age 35, is 40% of embryos have abnormalities, or age 45? So yes, at age 35, typically from a pool of embryos from an average 35-year-old, 40% will have spontaneous abnormalities and not be viable. And even under 35, which is about as low as we see, it's usually still 25 to 30% of embryos have abnormalities. So unfortunately, at all points of our lives, there is a low frequent baseline where our embryos make mistakes. It is hugely a large part of the reason why we don't necessarily get pregnant every single month we try. It is unfortunately why so many women experience at least one early pregnancy loss in their lifetime, especially if they ever have more than one pregnancy, because these abnormalities are common at all points of our lives. And then the next question was, does being on birth control skew the AMH test result? So birth control pills do not harm our fertility in any way, shape, or form. What happens in birth control pills is back to that, like our eggs are in a vault in our ovary, and each month we release a group to the surface of both ovaries. And naturally, one of them grows and the rest get discarded. That process still happens if somebody is on birth control pills. It just, the birth control pills prevent the one from ovulating and taking off. So the whole group starts to come and the whole group just gets discarded. So we don't lose any eggs faster. Unfortunately, we don't keep any eggs. So it sort of keeps things status quo. Now, it does, because it prevents the eggs from fully growing. Sometimes if somebody is on birth control for a very long period of time, we often do see slightly lower AMH levels that is reversible when that person goes off of the pill. So it's not that the birth control causes egg loss, it just makes it a little bit harder to detect that hormone, which we do take into consideration when interpreting AMH levels for somebody who's been on birth control pills for a long period of time. It is also why we usually use the ultrasound with the AMH level rather than just one data point, so that we can get an overall picture. If the AMH level is very low, it's probably not as low as it seems, but it's probably not going to be completely normal when somebody goes off the pill. But if it's slightly lower than we would expect, a lot of times and especially if we see normal follicle counts, a lot of times it will normalize when somebody is off of the birth control pills. Next question is, if you have a low AMH and low egg count, do you have to do multiple retrievals for multiple children? So obviously there's never a requirement of how many eggs you have to have in storage or how many cycles that you need to do. But I would say if you have a low count and you're getting a lower number of eggs per extraction cycle, it is probably going to be in your best interest to think of doing more than one retrieval cycle, especially if you know you want multiple children. Because of that funnel down we talked about before, there is very much safety in numbers when it comes to egg freezing. And so typically after an egg freezing cycle, you always kind of want to speak with your fertility physician to review your goals and how many eggs you have in storage to see if you're meeting your goals or if doing another extraction cycle is something that you should consider at some point in time. The fastest you could do another egg retrieval cycle, because that was the next question, is with your next period after the first egg retrieval. So once we extract the eggs, most people get a period about 10 to 14 days later. And that is the fastest you could restart medications. Some people are in that mindset, I just want to get this all done, and they want to do back-to-back cycles. It is somewhat of a time commitment that you're coming in every other day. So I've had some people that do a cycle and then I'm going to do a second one, but it's going to be 2-3 months later. It's too hard to do them close together. So you don't have to do them back to back, but medically we don't see worse outcomes by doing them back to back if somebody wants to that as an option. And if we're on the birth control pills, can we get solid counts on the follicles? Yes, typically the follicles are often smaller, but they typically are still seen when somebody is on birth control pills. Back to that, the physiology is that that group of eggs still gets released when you're on the pills. You just don't ovulate the one. So usually we do see it. The AMH levels are often slightly lower, but this is more if you've been on the pill for really long periods of time. If someone has only been on them for maybe a couple months or a year, we don't see those impacts as significantly as someone who's been on birth control pills for maybe like 10 years. And then what are the advantages of freezing eggs or embryos? So we kind of touched on that a little bit already. The main advantage is embryos are more stable and that they can be tested. So you have a better sense of what you have in storage. And typically about 98% of embryos survive thaw once they're frozen, while it's closer to about 85% of eggs survive thaw. So our funnel down is always slightly steeper when we freeze at the egg stage versus the embryo stage. And does your protocol differ for people with surgically confirmed endometriosis? So endometriosis is a medical disorder where the lining of the uterus can implant in other places, like on bowel, ovaries, fallopian tubes. And it can make it harder to get pregnant. It doesn't always, but it is a risk factor. How we grow and extract eggs, if the endometriosis has been surgically excised, is going to be the same as somebody with or without endometriosis. If someone has endometriosis that is still there, meaning let's say we see big cysts of what we call like endometriomas, that is something that we cannot, we don't want to spread or rupture a cyst during an egg retrieval. So that is always a conversation worth having if large endometriosis is seen, is whether that endometriosis should be surgically removed before undergoing an egg retrieval, or does it look like it's not impacting our ability to extract eggs? Sometimes it is and sometimes it isn't, depending on size or location. But the medications for growing and extracting the eggs are the same, whether someone has endometriosis or not. sometimes how we transfer an embryo back, different protocols depending on how significant the endometriosis can be, a little bit different, depending on the situation and how severe the disease is. Um, and then somebody asked a question about how sperm can affect fertility. And so men are very different. They always make and produce new sperm. It's a little unfair. They're not born with all their sperm and lose it over time. That being said, most men make new sperm about every 72 days, and it is still 40% of couples that end up struggling to get pregnant. The sperm is a leading factor of what's going on. So the sperm does matter. Everything is not just the egg. At any age point, a man could have abnormalities with their sperm, or they may not, and a semen analysis is always the best way to assess for that. If you have frozen eggs, we always want the partner to have a semen analysis before we plan to thaw those eggs, because if there's issues, we want to know ahead of time. We do often start to see more commonly abnormalities in sperm with men above age 40. So we don't see as drastic changes as we do with eggs and egg quality, but there does seem to be some age related impacts and effect. And quality of sperm really significantly impacts fertilization rates and embryo development. So we can get bigger drop offs if we see really poor quality sperm, or we may get not as much of a drop off from that egg to embryo stage if we have great quality eggs and great quality sperm. So both aspects do matter. Um, and should a man consider freezing sperm to increase the likelihood of a healthy pregnancy? I think because we don't see as sharp changes in fertility with sperm as we do with eggs, it's something that's not as common. But I've had some men consider that as an option, and it is something that could be considered, especially if we know that there's issues already at a younger time point. Um, and so I'd say it's not as common practice. It's not completely unreasonable to think about either, depending on a situation. And the next question is an AMH level of 1.5 normal at age 33? So typically what we consider a low AMH level is anything below 1, is sort of in a range of eggs where we think that it seems like there's been significant egg quantity loss. And so that is technically kind of what we consider a really low level. That being said, we always want to interpret AMH levels based on age as well. And so the average person at age 33 typically has an AMH level somewhere between 2 and 3. So 1.5 would be considered slightly below average, not in a critical level or dangerously low level, but slightly below average for that age group. But as I mentioned, it's also looking at the follicle count and a full picture. And another birth control question was, do you only need to be off of it for the month when you go on medications? So that typically depends on your AMH level and how long you've been on the birth control pills. So typically, at minimum, you need to be off of the pills 4 days before you start the medications to grow and extract the eggs, and you need to stay off of it that full month or cycle that you're growing and extracting the eggs. There are some individuals where your doctor may recommend going off a full month before you even start rather than 4 days. If you've been on the pills for a very long time, if the AMH level looks much lower and there's concern that there's a lot of suppression from being on the pill for a long time, or if it's really struggling to see those follicles, then sometimes we do recommend going off for longer periods of time. But I would say for the average person, usually they only need to go off of it about 4 days before starting the cycle. So the benefit of not having to go off the pill for long periods of time is you have a lot of control over scheduling when you want to start. While if you're not on the birth control, we always wait for your natural cycle to start. But sometimes it truly looks like somebody might have a little bit shorter stimulation, meaning when we see a lot of suppression from the birth control pills, our studies don't show a difference in total number of eggs extracted, whether someone goes off the pill for longer or shorter time frames. But what we do see a difference is sometimes people are on the injections for days longer than they would have been if they, when they were, if their ovaries were really suppressed. If they went off the pill, we see that they just respond faster. And sometimes it's not fun to be on injections, and the medicines can be expensive. So sometimes that's a benefit that's worth exploring. Um, Next question is, what happens if you freeze your eggs in one state but live in a different state or country? As far as within the United States, you can always ship eggs. So, meaning if you live somewhere else and you want to have your eggs shipped locally to a fertility center where you live, you can do that. Some people just come back because the actual embryo transfer is a much easier process. It's truly about a 10-minute procedure. It's more similar to a pap smear, where a speculum is placed in a little catheter through the cervix of the embryo is placed in the uterus. So you really only have to be local for a couple of days for an embryo transfer. We always want you here at least the day before we are going to thaw, to put something back because we don't want your flight getting delayed and we have an embryo waiting and you're not here. But you really truly could come the day before and leave the day after the transfer. Um, if that's easier, some people, depending on where they live, they have a lot of fertility centers. It's easier for them to ship eggs. Other people, it's easier for them to come back to New York for a short time frame. Now, out of the country, that can be a lot more complicated. Every country has different laws and regulations on freezing eggs and embryos. And so if you would really need to see what country it was and if they would be willing to accept those eggs. I would say it's very difficult for us to accept eggs not frozen in the United States, in the US, to the point that we typically don't at RMA. And so that is definitely a lot more tricky and a lot more challenging. It's a little bit easier sometimes when it comes to embryos. Every eggs are just more fragile, that different protocols are used at different places. So your thaw survival, we always worry, may not be as optimal, especially if it's not within the US. And so I would say if you knew it was going to be a different country, it would probably be better to either come back or freeze eggs in that country where you plan to use the eggs in the future. And another question is, does the process or egg viability affected by PCOS? Um, PCOS can make it harder to get pregnant naturally for individuals who have it. It's a metabolic disorder where a lot of times women have very irregular periods and irregular ovulation. And the irregular ovulation is the main link with why it can be harder to get pregnant, because if we're not, we have to ovulate to be able to conceive. The injection medicines for egg freezing work the same if someone has PCOS. So it doesn't impact that process. It is more common that sometimes women with PCOS are more sensitive to medications. And so it's more common that we see higher AMH levels. So sometimes they need, it's not a one size fits all, but sometimes women need a little bit lower doses of medications. But the actual growing, extracting of the eggs, the process is the same whether someone has PCOS or not, but it can have impacts on natural conception, especially if someone has very irregular periods with it. Let me see. I asked, does our facility do semen analysis? And yes, we do semen analysis. And that is one of the testing that we do require if you are thinking of freezing embryos rather than eggs. That is something where we have sterile collection cups, and someone can either collect a sample at home and bring it into the office to be analyzed, or we have actually sperm collection rooms that someone can book a room if they want to come in and collect. And our andrologist can analyze the sperm and see the count, meaning how much sperm there is, how much is moving and swimming, the shape of the sperm, all parameters that if they're abnormal can make it a little bit more challenging to get pregnant. And we also do have a urologist or a male fertility specialist at our clinic as well, so that if we see any abnormalities with sperm, we typically refer to urology for further evaluation. Next question. was I took birth control pill throughout college. I stopped for few years and started up again a few months ago because I was trying to manage a couple of small cysts. How does that impact my fertility? The birth control doesn't negatively impact fertility, so that it should not have any issues. Cysts are common, they come and go quite frequently. We only usually get more concerned about cysts that persist, ones that may need to be surgically removed because they look like they're causing pain or issues. But small cysts that come and go usually don't have any long-term impact on fertility as well. Um, Question was, my thyroid level is 4.1 and my AMH is 8.6. I tested due to some cysts discovered in scan. Should I be planning to freeze my eggs sooner rather than later? Um, so the AMH level of 8.6 is quite high. So that we sometimes see that with PCOS, although it not necessarily, some people just have high egg counts. It's definitely worth a full evaluation in that regard if you haven't had one yet. Thyroid level of 4.1 is usually a level we keep an eye on. So for someone not trying to get pregnant, that's in the high normal range. For actual pregnancy, we typically like to see a TSH level below 2.5, just because during pregnancy, the baby takes your thyroid hormone. So if your level is in like a little bit of the borderline level, it could put people into hypothyroidism. So that's usually just something to periodically have checked. But there's medications that can treat thyroid if it ever was in a range where medications was needed. So I wouldn't expect any long-term fertility impacts based on that. As far as whether to freeze eggs, given those testing, really, I would say the big reason why someone should consider freezing their eggs is truly when you think you're going to start your family and how many children you want to have. And if any of those like family building goals are in, going to be late 30s or older, then no matter what testing shows, whether it looks severely abnormal or picture perfect, then you should be considering freezing eggs, because age is our number one predictor of who will get pregnant. Um, if someone has PCOS, some people do consider freezing eggs more, just because if they're having irregular ovulation and periods, it might be a little bit more challenged to get pregnant naturally. So it's never wrong to be thinking about it. But, truly, I would say age and number of children and when you're going to start your family really should be the number one driving decision making factors on if someone should freeze their eggs or not. And um, and is there a consultation available to see if egg freezing is recommended more immediately versus in the next few years? So those are typically things that are gone through for all egg freezing consults. So at RMA, we have a lot of different offices and locations. I work in our Soho office downtown. We have one on Madison and 60th Street. We have one on 57th Street and 8th Avenue. We have Brooklyn, Westchester. So truly that first appointment, it's typically about an hour long consultation, is just going through your medical history and your goals to get a sense if egg freezing is something that you should be considering, and doing that testing to look at your egg reserve. And so that is true. Like, it doesn't mean you have to freeze your eggs if you make an appointment. It's really kind of going through that and talking through those pros and cons. And so that's truly what any of those consultations are. And some people decide this is something that they should be doing and they should be doing sooner than later. And some people just reevaluate, and maybe it's something that they'll consider if in a year if they're not starting their family. So yes, that it's perfectly reasonable to do a consultation to kind of help tease out when you should be doing this and what the right timing is. And then irregular periods, does it impact the egg extraction procedure? So typically, no. The medications to grow and extract the eggs work still quite well, even in individuals with irregular periods. But for getting pregnant naturally, someone with irregular periods is almost always ovulating irregularly. So that can mean that medications or intervention might be needed to get pregnant naturally outside of this egg freezing kind of embryo freezing IVF process. But it doesn't impact. The only difference would be we normally start your medicines when your period comes. So for people who go like 3 months without a period, we check the hormones. It's not the period, it's not the bleeding. We just want to start when you're not about to ovulate, which is when your estrogen and progesterone level are low. So most people with irregular cycles, their levels are usually often low, where we can just start at any time. And then the last question I have is, what is the cost for egg freezing? It's truly variable, depending on insurance. I will say it's about 50-50, is what we typically see at RMA, meaning half insurances cover it, half don't. And then it also depends on how many cycles you need, if you think you're going to need more than one cycle, and medication costs, if that's covered or not, because that some people need lower doses or higher doses of medication. So I would say probably the extraction portion, if somebody has absolutely no coverage whatsoever at all, is often in about the $10,000 range, although that can be variable. And then medications on top of that can be extra costs. We have financial advisors at RMA, that typically meet with all new patients, and then they can query with your insurance and let you know if you have coverage for freezing your eggs. Like some people, truly everything is covered. Some people, nothing's covered. Some people, the medicines are covered, but this isn't, and they can kind of work with you and get you all those information. Or if you wanted to speak or get that information, you can always call before booking an appointment as well. Or you can always speak with your insurance company and call and ask them if they have coverage. So I think that was the last of our questions. That was a lot of great questions. I'll put my email in the chat so that if anybody has any further questions, you can always reach out to me. It's K Thornton, my last name THORNTON at rmany.com. And I think if anybody, if you're on the fence or you just want more information or more tailored to your medical history, your age, your numbers, always, coming in, I would say most insurances do, there's a good portion of them that at least cover the consultation. So sometimes even if egg freezing isn't covered, the consultation to talk about it and do the testing often is. That's something that obviously we can tell you before booking an appointment. So sometimes it's worth just getting the information so that you can see what your coverage is, you can see what your situation is, and you can make those decisions. So I thank you very much for everybody, and I'm gonna log off now. But if you have any other questions, don't hesitate to reach out to us, or you can always make a consult with me or any of the physicians at RMA of New York, if you had any further questions. And everybody have a good night.